Post ERCP pancreatitis is a significant complication associated with ERCP. It's particularly associated with interventions to the pancreatic duct. There are interventions performed to reduce the risk of developing post ERCP pancreatitis, such as the administration of rectal non-steroidal anti-inflammatory drugs during the ERCP procedure. There are options to perform pancreatic duct stenting in the event of PD cannulation with a guide wire, which is thought to reduce the risk of pancreatitis. We aim to analyse retrospectively the data we had at our single large DGH, which performs ERCPs, in order to ascertain whether this practice significantly reduces the risk of developing pancreatitis, and if so, the severity or complications or length of stay associated with this post-ERCP complication. As demonstrated, our information was collected over a 7-year period involving 2,028 patients. All these patients were undergoing ERCPs with the idea of selective colon bile duct cannulation. No patients with pancreatic duct directed intervention were included in this study. In total, there were 1,469 patients who did not have any PD, wire or contrast injected during the ERCP, 348 patients who had contrast but no PD stent / PD wire but no PD stent inserted, and another group where a PD wire or contrast injection occurred but a PD stent was inserted, encompassing 211 patients. There was no statistically significant difference in the mean age across these groups. Further information such as the male to female ratio in groups and the ASA status is recorded as below. In total, we noted that there was a 2.5% risk of developing pancreatitis if there was no intervention to the pancreatic duct, which increased up to 4.3 or 4.7% in the groups with pancreatitis, pancreatic duct involvement. This was a statistically significant difference, and does suggest that PD duct cannulation or contrast injection increases the risk of post-ERCP pancreatitis. All patients underwent rectal NSAIDs during their procedure. We note that the severity score, as per the Modified Marshal and Atlanta criteria, were not significantly different in PD with stent group versus the non-stented group. There was no statistically significant difference in the length of stay amongst these groups, nor was there any statistically significant difference in ITU involvement or the number of deaths associated, although the number of deaths in the PD stent group does almost approach statistically significant values compared to the non-death group. We conclude from our study that PD stenting post-PD intervention in non-PD directed procedures does not significantly reduce the risk of developing post-ERCP pancreatitis, nor does it reduce the total length of stay, nor deaths from this complication.